Dear friends, I'm Dr. Parthaji Das, consultant rheumatologist in Calcutta, and I'm the co-editor of this March issue in IRA newsletter. See, we welcome you all to enjoy this IRA newsletter podcast, and the theme is pitfalls in DXA interpretation. We have with us Dr. Puneet Mashru. He's the head of Department of Rheumatology, Sir H.N. Reliance Foundation Hospital, and he's working as a consultant rheumatologist in Jaslov Hospital and Bridge Candy Hospital. Now, we all know that osteoporosis is an emerging problem with increasing prevalence due to aging population in India and across the world. This is very poorly managed and very poorly diagnosed in various parts of India as well, if not across the world. And we all know that DXA is probably the only modality, only the technical modality we have to diagnose or detect bone mineral density. However, there are various potential pitfalls and limitations which should be taken into consideration when we are interpreting a DXA scan. So without wasting time, we would like to discuss few things. What are the pitfalls and limitations with Dr. Puneet Mashru? So let me ask the first question. So the first question is, Dr. Mashru, can you tell us what type of DXA scan we are going to ask for to start with?
Yes, thank you so much for the opportunity. So when we ask for DXA scan, we got different options. So we have whole body, spine, femur, forearm, lateral DXA, that's a vertebral fracture assessment. So in adults, we should be asking for spine and hip in all our patients. Forearm should be measured if if the hip or the spine cannot be measured or interpreted, or the patient has condition like hyperparathyroidism, or the patient is very obese, which is above the weight limit for a DXA table. Now, commonly patients will get their forearm done, and when we interpret the DXA, we should not, if the spine and the hip is valid, then we should not take the forearm reading into consideration, because forearm BMD does not affect morbidity and mortality. A lateral DXA or a vertebral fracture assessment is a very, very important tool, because a vertebral fracture will change your treatment, will change your investigations. And often these fractures can be silent. So a lateral DXA indication is in elderly women above 70 years or men above 80, if there is a history of height loss, if there is a history of a vertebral fracture, or a patient is on glucocorticoids of 5 milligrams or more, equivalent for more than 3 months.
Right. Yeah, I think that comes to our next question. Can you please highlight the basic technical aspect of DXA assessment? I think we have quite a wide range of viewers, like the physicians, with the MD students, DM candidates. So this would be very useful for them.
Correct. So when we open a DXA scan image, it is mentioned there below that image not for diagnosis, but we need to look inside to see whether the scan has been done properly or not, because we depend on a technician to do a scan. So in the spine, what we're looking at is the global window. The global window is basically the entire spine, the entire image that is captured in the DXA scan. And in the spine, what we're looking at, it should include part of the T12 vertebrae with the ribs, and should include the L4, L5 pelvic brim. The next thing what we're looking for is is it centered and is it straight? So it should be equidistant and straight. Then we should make sure that it is labeled correctly, and these lines are in the intervertebral spaces. And the last thing what you're looking at are these lateral margins. In the femur, the global window should include the acetabulum, greater trochanter, and should go below the lesser trochanter. The positioning should be that the femoral shaft should be straight with 10 to 25 degrees of internal rotation, with little or none of the lesser trochanter should be seen. And again, we should trace the lateral margin. So this is to see whether the DXA machine has picked up the bone or not. Then we're looking at the femoral neck box, and the position of the femoral neck box differs from the manufacturer to manufacturer. For example, the GE machine would pick up the the weakest part of, or the narrowest part of the femoral neck, while the hologic picks up the more distal part of the femoral neck.
I think, as you rightly said, many patients who have wear and tear, a lot of osteophytes in the spine, we can easily kind of get rid of those extra bony if we can look things properly. So that will
Yes.
get rid of the erroneous results, really, which we all need to
Absolutely.
know. Now, let's come to your next question. So, what are the common technical errors that contribute to a wrong or kind of erroneous results?
Yes. So first is the positioning. This, you can see the global window. This patient has been positioned very high up, and you can see that L1 actually is it's the T12 vertebrae. So this is absolutely a scan that we cannot salvage. Here the scan is started too low. The position has been the position of the patient is placed very low, and here again we cannot salvage the scan. This is a spine. The patient has been, the spine is not straight. Here we can see that these lines are not in the intervertebral spaces. And if this occurs, we can tell the DXA scan center to put them in the correct spaces. So this is all that they have to do. They have to put it into these valleys, as you can see here. And yes. Also, we need to look at the serial T-score. So if you see that an adjacent T-score, if there is more than one standard deviation difference between both of them, then there's likely some artifact or some issue that is there with one of the vertebrae. And generally, the one with a better T-score is generally the one which needs to be excluded. So you can see that when we excluded the scan, excluded the erroneous the T-score, the L3 vertebrae, it became from osteopenia to osteoporosis. The positioning is very, very important. And to highlight that, the patient, you can see the same patient where the femur is not straight, it is abducted, and the femur, the position is corrected, and you can see the difference in the BMD, a significant BMD change. So the positioning has to be just right. And one of the reasons is that on the DXA table, especially the GE1, they have this triangle. And if the technician places both the legs together simultaneously and does the measurement of the femoral neck without adjusting the positioning, it will lead to an abducted femoral neck position. This is a typical movement artifact of very, very common because the patients don't keep their hands still. So there's a movement artifact. This is a post THR artifact here. So you cannot take this into consideration. When we do the hip BMD, the hand of the patient has to be on their chest. But here the patient had put their hands on the femoral area, and the finger is adding to the BMD of the femoral neck, of the femoral femur side.
That's very interesting.
Then sometimes obese patients, they're very, very obese, their fat may overlie the femoral area, and that can falsely elevate the BMD. So they have to lift up that extra fat and hold up that fat when the BMD is getting done. This is enthesitis, which is adding to the BMD. Here you can see a vertebroplasty has been done, and that has been added into the DXA thing, but that needs to be excluded, the L1 vertebrae, as you can see here. So here the patient has undergone a spinal surgery with plating and all, and this scan cannot be taken into consideration because you need at least two vertebrae to make a diagnosis. So the one on the right can still be used for diagnosis, but the one on the left has to be excluded. In our field, ankylosing spondylitis is very, very common, and when the patient has these bridging stent desmophytes, the DXA scan is unreliable, and in such situations, then we may have to take the forearm into consideration, or maybe use another technology like a QCT to make a diagnosis. This is artifact of a safety pin on the other spine. Sometimes in our elderly population, there's a lot of aortic calcification, and this aortic calcification can falsely elevate the BMD. So getting a lateral DXA, especially in the elderly population, gives you an idea also about the calcification. So whether to consider this BMD value or not. This is a scan where you can see that the lateral margin has not been picked up by the machine. The machine is going to make mistakes, and we have to closely look at these things. So you can see that on correcting it, the DXA, the value changes. This is a scan where the femoral neck box is completely out. Here you can again see the lateral margin is not at all, it's not overlying the ulnar and radius. So it is out of the box.
Right. I think that's very interesting. So that comes to our next question. So what are the common errors while we compare DXA scan? But is it really possible to compare DXA scans? So that's the question we need to ask now.
Yes. So when we use a DXA comparison to see whether there is any change in the BMD value. So if for example, you're a patient who's on treatment, you want to see that whether there's been a change. And the site where you are going to monitor it is the preferred site is a spine. If a spine cannot be used, then a total hip is preferred. Forearm is not generally preferred because it doesn't respond well to treatment. Now, when we're comparing DXA scan, we have to importantly compare the BMD value and not the T-score. It should be on the same machine that has been done previously, ideally by the same technician. We should be comparing the same region of interest. Now, every machine and every technician has an error value, and that error value has to be calculated, and that is called a least significant change. Today, if I get a DXA scan done on a particular machine and I repeat a DXA scan at the same time, there will be some variation in the readings. So we should know what is an error value of that thing, and that has to be calculated by the DXA center, which often is not done in many parts of the country. Also, we should keep in mind what is the rate of bone loss in a postmenopausal woman, and what is the rate of bone loss in accelerated bone loss. For example, if we put our patients on glucocorticoids. So this is something important to keep in mind when we are monitoring and looking at serial DXA readings. I'll explain about more about this later. So let me give an example. For example, baseline spine BMD is 0.981. A repeat spine BMD is 0.932, and the difference between both of them is 0.049. So the error value or the least significant change of that machine is 0.031. So it is exceeding, it is beyond that error value. So the change is significant. Let's take another example here. You have the BMD value in 2014 as 0.707, in 2017 as 0.712, and the least significant change value is 0.022. So it is within that range. It is not exceeding that range. So there is no change in the BMD. The BMD is stable. However, let's look at this scan. You can see that 2013, the BMD value was 0.697, and in 2016 it was 0.760. So there is a remarkable difference of 0.063 grams per centimeter square, and it is beyond the LSE value of 0.029. So the change is significant. Coming to the errors, a common error. So I'll give an example of this lady, a 54-year-old female, whose BMD in 1 year decreased by 9%. And this is the scan image. But if you look closely, the labeling of the one on the left, you can see that the L1 vertebrae actually is incorrect label. This is T12, and that is why there is such a remarkable difference in a BMD. So 9% BMD loss cannot occur. If something dramatic like this is there has to be something wrong with the scan. Let's take another example. A 64-year-old female, there is an increase in BMD of 0.820 to 0.865, and the patient on alendronate, patient should be very happy. But are we really happy? You can see that the the one on the right, the L1 vertebrae, the height looks decreased and the patient has had a vertebral fracture. So vertebral fracture can falsely elevate the BMD. So actually, this is a treatment failure as such, and the patient needs to be changed. The treatment line has to be changed. So we can see that for comparison, they have used T-scores and they have said that there's a decrease of minus 2.1, minus 6. But we compare the BMD values and not the T-scores.
Now, I think that's again very interesting. So next thing is, what are the common errors when we report DXA scan?
Yes. So these cases that I'm showing you, these are routine cases that we get in our OPD. And here you can see that here they have taken wards area as the region of interest, and they've labeled the patient osteoporosis. But the two sides that we're looking at, the two region of interest that we take into consideration is a femoral neck and a total femur. We don't take any other areas as a region of interest to diagnose osteoporosis. And you can see actually the BMD is normal. The total and the femoral neck both are normal. Here you can see that they have taken a single vertebrae to make a diagnosis. So like an L4. So we don't do that. We need at least two vertebrae to make a diagnosis. Here we can see that they have taken a trochanteric difference as the region of interest, which is again incorrect.
Yeah, the next question is, I mean, what is the role of DXA scan in steroid-induced osteoporosis?
Yes, and so with in GIOP, it has been seen that a fracture occurs even at a higher BMD. So even in osteopenic range and normal BMD values, there are fractures that occurs. It is because of a change in the microarchitecture. So BMD does not pick up it's not able to assess the microarchitecture of the bones, and so we use the BMD values and we put it into FRAX, and this is the ACR guideline for treatment of GIOP. And you can see that it uses the FRAX and the BMD values to come to a diagnosis and to help us whether we need to treat these patients or osteoporosis. With regards to diabetics, even again, diabetics fracture at a higher risk. And for example, if a patient has a femoral neck of minus 2.2 and minus 2, are we going to treat these patients? So again, here the DXA doesn't assess the microarchitecture, and that is why these patients fracture at higher BMD. And to overcome this, there are certain recommendations. So for example, a diabetic patient, we get DXA scan done. What we can simply do is we can add minus 0.5 to it. So here the patient's femoral neck T-score is minus 2.2. So you assume it can be minus 2.7. Or the other way to do it is that we can put rheumatoid arthritis as an yes in the FRAX scoring, and again that will help us. Or the third way for these patients of GIOP and diabetic patient is add something known as a TBS score or adjust with TBS. Now TBS is an additional software which is on the DXA machine, and it assesses the trabecular bone architecture using a software, and it gives you a value, and this value you put it into the DXA, the FRAX scoring. So patients who are diabetic and steroids generally have a lower TBS score compared to the other people.
Yeah, I think we will probably coming to our end of our sessions. The last question is, how can you differentiate in between the osteoporosis mimics like osteomalacia, metabolic bone disease? So what are the main key features we have to look around?
Correct. So DXA is very difficult for DXA to differentiate between osteoporosis and osteomalacia and other metabolic bone diseases. I think we have to take the overall picture, the overall lab findings and the clinical scenario into consideration when we diagnose osteoporosis. This is especially true in a younger population. When you get a young person who has a low BMD, that's a time when we must rule out other metabolic bone diseases. I'll give you an example. This is a 26-year-old female who had some body pains. aches and pains, and the gynecologist enthusiastically got a BMD done. And you can see that her Z scores were very low, very low. But she had osteomalacia. Her vitamin D was low, calciums were low, alk phos was high. She had osteomalacia, not osteoporosis. And all she was given is vitamin D correction. And you can see a couple of years later, her BMD is normal. And that's about it. A dramatic increase in BMD. You can see a 59% increase in BMD values at the spine and 57% at the hip. I'll give another example. A 38-year-old female who had was lifting a bag and had a vertebral fracture and was advised DXA scan by a spine surgeon. Here you can see the BMD values, the Z scores are very low. And she has an L1 fracture. So if you see the serial Z scores or the T scores, there is more than one standard deviation difference. So that tells you something is abnormal with the L1 vertebrae. She had a fracture. Again, it's low. So the patient, the orthopedic discussed vertebral plasticity, teriparatide, but basically the patient had hyperparathyroidism and because of a parathyroid adenoma, underwent a surgery, and just treating the underlying cause, you can see that the BMD is normalized. So you can see 72% increase in BMD at the spine and 63% increase in BMD at the hip. So just treating the underlying cause changed it. So DXA cannot differentiate between other metabolic bone diseases, and we should keep that in mind.
Yeah, I think that's right. Dr. Mashru, thank you very much for nicely discussing the pitfalls and limitations of DXA scan. We shouldn't forget that DXA is a kind of measurement of the bone density, which is basically around 50 to 60% of the whole bone strength. We are struggling to measure the bone quality, especially you need either QCT or the TVS score for that. But this is a matter of discussion. We'll probably discuss in a next meeting. We hope that you guys find it very useful, and please feel free to share your comments. You're more than welcome to share your comments in the podcast. With this, I would like to close the session today. Thank you very much for joining us. Thank you. And thank you, Dr. Mashru, once again.
Thank you so much.